Thanks, Pat. If I can ask the panelists to please come up to the table, and we'll open up the microphones for questions. I'm sure there'll be several. Yes, please.
David Litwack at FDA. So I wanted to ask, just to nobody in particular, but to the panelists, there are a lot of messages that patients and even physicians will get from marketing, from the internet, from Dr. Oz, So to what degree do you see those messages interfere with the evidence that you're all trying to communicate to those groups?
I think speak.
Okay, speak. I do think it's a major issue because the media portrays these new technologies as being cheap and as always being good. In other words, the more information is always better. When we know that more information is not always better, when we know that it's not cheap. So I think the media is actually doing a disservice and leading people to expect things that really, once they understand the full consequences, they go, well, actually, I don't want to know all of that. Or, it's not worth paying for.
I mean, they talk about the $1,000 genome, but they don't tell you that it takes $10 million to buy the equipment to give you the $1,000 genome. And they advertise personalized medicine like it's the cure for cancer, but they don't tell you all the challenges that we're still facing trying to get the answers to those questions. But they are promoting personalized medicine many times, which does give us the advantage because patients are now getting educated enough to start seeking it out and asking questions.
And I would just echo that. I mean, patients that come to see us, and I'm enthusiastic about the concept, but the key missing link is often there's not a lot that's actionable yet. Right. So we're left with all this information and then, this test, and it's the companies too that are promoting it as the be-all and end-all. And that list of trials that you may have for a given patient, it's not practical for the vast majority of patients. You're sending them to the other side of the country. That's not going to happen. So unless you have a basket of trials at your own institution, many times the information, I wouldn't say it does more harm, but it's not actionable for most patients.
Before we move on, let me ask a follow-up. You mentioned Dr. Oz, but I'm thinking, what about the primary internist, the first responder that sees many of these patients? And we haven't even talked about that yet, but many of these patients come in, the biopsy is not done by someone in the oncology community. How do we deal with that?
I think it's horrible.
Hopefully he's not ordering genetic testing or genomic testing. And I mean, if it's an incidental finding, I think, especially if he's treating the family, he's probably going to need to get involved eventually. But I think Bill's right. It's kind of horrible unless he is some rock star internist that knows everything, because he can actually lead to more harm than good.
Yeah, and Pat made this point, even among, supposedly sophisticated subspecialists, I would submit that most of us aren't equipped to have that conversation with most patients about what the results actually mean. And furthermore, we don't have the infrastructure in an RVU-driven environment to really, in an efficient way, empathetic way, deal with the information. And that's at the oncology level.
Exactly.
I'll just say that we sometimes get criticized by the manufacturer, although my experience with oncologists is they support this highly, is, for example, our medical policy for Oncotype DX testing says that it has to be ordered by the physician who's going to be making the treatment decision, as opposed to the surgeon or someone else who's not necessarily going to have that conversation with the patient about how the information will be used.
One of the things that Catherine also said was that many of the community oncologists are buying into profiling. Where I was previously, that was the case. I couldn't get my own institution to buy into profiling, but I'd say 95% of my patients that were profiled came from the outside, from the community oncologist, who would profile a patient and send them to me. They usually couldn't act on them. They couldn't act on them at all, but and in fact, I believe there was a study from Cancer Treatment Centers of America who profile all their patients, but I think they act on only 2 or 3% of the profiling that they do. But they're all over the billboards. We profile your tumor. It's a lot of money for nothing.
Let's take another question from the right.
Okay, my question relates to revision of guidelines. So I've sat on many panels, they're coming up with these guidelines, and appreciate, as many of you do, how difficult it is to evaluate this body of evidence for biomarkers particularly. So what mechanisms does, say, WellPoint have or NCCN have for updating guidelines? So you've made a decision, for example, in WellPoint that certain pathways are acceptable pathways. And 5 years later, what are your mechanisms, if at all, for going back and saying, okay, well, maybe our initial decisions weren't quite right and we want to change things. So what is that feedback loop? And the same question for NCCN.
So for us, we basically have developed an approach to systematically review the guidelines that are out there, NCCN, ASCO, new FDA-approved indications, and evidence that gets published in major clinical journals during that quarter. And we'll look to see if we update our outcome summaries based on that. And then if there are any material changes, review that with our advisors to see if we need to add or remove something.
Okay, and so do your own data go back into that decision too?
At this point, so since we just started the program, we're just starting to collect our own data. And I think, it's possible, for example, that we may have data on hospitalizations with different treatments that will be valuable. But I think given that our standard for everyone else is that data should be peer reviewed, we may start to use our own real world evidence, but it would be, in parallel with publishing it and having it be in the public domain at the same time.
So we actually have a very systematic, extremely tedious way of going about it on an annual basis. So each of the member institutions has an opportunity to look at the guidelines annually in anticipation of the face-to-face meeting. And then each of the pathways or pieces of the algorithm, so they provide comments. So if something has changed, those are incorporated into the agenda of the face-to-face meeting. Somebody's assigned to look at that particular node or area of the algorithm, and if there's sufficient information that would warrant changing it or modifying it or changing the language in some way, that would be implemented at the face-to-face meeting.
Thanks.
Two other things that I forgot to mention. So one is that on the website, we have an email address. So we take comments from anyone who provides comments, and we review those at our advisory meetings. And we've actually had some very good dialogues with some of the patient advocacy groups and have had changes made based on their input as a result of that. And then the second thing is that, again, the program just started, but what we anticipate is that we'll start to review as we review adherence to the pathways, we'll be looking at those regimens that are, quote, not on pathway and see if there's like a particular trend that maybe there is a particular subset population that we haven't identified that we should explicitly create a pathway for.
Great, thanks. On the left, please.
Fabrice Miedowskis, University of Chicago. Building on that last question, I guess maybe bigger picture question, do we think the omics era is improving or lessening the value of clinical practice guidelines? And I can see sort of some trends in both directions. I mean, on the one hand, as patient subgroups get more and more splintered due to sort of genomic biomarkers, that would make it harder to keep updating those guidelines for those smaller and smaller subgroups over time. On the other hand, one of the charts that Jennifer put up, NSCLC with no biomarkers has like 61 different treatment options. But as we've seen a few times, some pie charts of that 50% of patients who get sequenced have a biomarker in NSCLC that's clinically actionable now. So I would imagine that list of 61 treatments for untargeted patients is becoming less and less relevant as we find more patients who have targets that have presumably narrower guidelines available to them, fewer options for them. To me, that would suggest that improving genomics knowledge is improving the use of guidelines by making them sort of more restricted, and for payers that could be helpful as well. So any thoughts on that?
I mean, I will just say that I think we're gonna continue to need guidelines. I don't think we have, there's Watson and CancerLink and, different computer systems out there, but I don't think we're at a stage yet where we can't, where we can give up the kind of collective wisdom and expertise. And I think when one of the big challenges are these reports that come out with so-called actionable mutations. The question really is what does actionable mean? And I think you need something like the guideline process to really define, does this actionable mutation, is this investigational drug or drug that's used over here actually going to produce a better outcome for this patient than the standard chemotherapy?
Right now, I would submit that most of the actionable things we have haven't been necessarily validated as translating into an improved outcome. Now, that doesn't mean that that's not a valid strategy. I mean, it is a strategy we all want to use when we enrich clinical trials or design clinical trials, and something other than a shotgun approach that we may have used in the past. But actionable so far for many of the, I would submit, is not translated into a better outcome yet.
Well, and let me add, referring to the ACMG recommendations, we just did an analysis of what's known about the economic trade-offs and the benefits and the cost of each of those genes. And there's almost no evidence on whether they provide value in not only in the clinically actionable sense, but in the economic trade-off of benefits and cost. So there's a huge dearth of knowledge.
Thanks. Richard?
Rich Shilsky from ASCO. So let me take you back to the 1970s, for those of you who can remember then, to when CT scanning was introduced for evaluating patients with cancer. And I was practicing medicine then, and in those days, if we wanted to know how the patient's liver metastases were doing, we would get a radionuclide scan of the liver. Then CT scanning got introduced. Now, CT scanning of the abdomen returns a lot more information than just about the liver. You get information about everything else that's in the abdomen. Sometimes you get incidental findings. Sometimes you find people have, a small aortic abdominal aneurysm, or who knows what. When CT scanning was introduced, as far as I know, the payers at that time, didn't say, well, gee, why should I be paying for these images of the kidneys and these images of the vasculature and these images of the lymph nodes when all the doctor really wants to know is what's happening in the liver? So why is genomic profiling different? I'd like to hear a little bit of discussion about that. We're characterizing the tumor. We're getting more information than perhaps the doctor, is immediately going to use. We're not, and we're finding incidental findings. It's exactly the same as when CT scanning was introduced in the 1970s.
Who wants that one?
I can take that one. That's a tough one, but let's keep in mind we're really talking about two different things. We're talking about payers covering panels where you're deliberately getting more information than you're looking for, versus we happen to be looking for something and we discover an incidental finding. Payers are very focused on the issue of panels where they know what you're looking for and they want to know whether what you're looking for is something they should be paying for. So that I see as a different issue than if you're looking and you happen to find an incidental finding. So I think it's important to keep those two separate. But I think you're absolutely correct that this is not really brand new, and there should be lessons that we can learn from previous experience that we can take forward to be able to resolve these issues.
Well, I'm not a geneticist or a genomics person that runs these panels, but currently, in order to really do a good job with incidental findings, you'd have to do, and Mia, you might be able to help me here. You'd have to run it for incidental findings, and you'd have to validate it if you're going to read them out. And if you don't validate it, but you report it, eventually it will have to be validated. if you're running it for incidental findings. Is that what you're saying? Well, I think. Right, and that's the problem. I think currently the way that the genomics is being run and the bioinformatics is being read out, it's really not sophisticated enough most of the time. And Mia, you can help me because you do this for a living.
If they have a gene on their panel, they have to validate the accuracy of that particular gene.
And most of those genes aren't on the somatic readouts because they have no relevance to the tumor that are on the incidental finding panel, correct?
Oh, you mean the ACME?
Yes.
Most of those genes are not on our tumor panel.
Yeah, that's the problem. And it's going to cost you another $5,000 to run the incidental findings.
But you don't have to run them. You're not obliged to run them.
No, you're not obliged to run them, but
So
if,
it's not going to cost anything because you should not run them if they're not already part of your design.
except that the ACMG is making those recommendations and you hope that there will be no legal ramifications as a result of it.
I wasn't around in the 70s when CT scans first got introduced, but I remember as a fellow that the kind of routine was to order the Chem 20. And the number one consult that you saw as a hematologist was for someone who had an abnormal protein albumin ratio. And we routinely did bone marrow biopsies on a whole bunch of people who didn't need it just because we scattershot ordered a test. So I think, there's, costs aside, I think there's reasons to be clinically thoughtful about when it makes sense to order a scattershot test versus when we should really be hypothesis driven.
That's a good point to move on to the next question.
Hi, Barb Conley, NCI. I just want to make a couple of comments. The NCI trials that are starting off right now with the National Clinical Trials Network, both LungMap and MATCH, have looked at this situation actually of the incidental finding or the secondary finding. Those two studies are not going to be running germline along with the tumor sequencing. They'll just be doing tumor sequencing. Nevertheless, there are genes on that tumor sequencing panel that could be germline. And there is a consensus among those who are running those that sometimes you could suspect that this patient might also have a germline issue, not just a somatic issue. So we really have taken this on. We have a sort of incidental findings working group in MATCH, but we engaged the genetic counselors on this, of course, and they were a little bit flummoxed because it's backwards. Okay, when the genetics counselor sees a patient, they see them with a clinical constellation and a history, a family history, and then they order the test. They don't get the test and then start from there. So it is kind of a new paradigm to be looking at what these things mean, and I'm hoping that, with SWOG, ECOG, the whole NCTN involved in MATCH and running that we will create a co-laboratory in certain parlance that we can actually look at some of these issues and study what it actually means.
Okay.
Okay, I have a couple comments, and I'll come back to that point because I do actually germline genetics for a living. But I wanted to comment because I have a lot of interactions with both academic oncologists and community oncologists in my former life. And it is very clear that community oncologists do actually order more panels. And I think it has to do a lot with the availability of what to do next with the patient, right? So academic oncologists are very used to be able to derive their patients to a series of clinical trials that are available at their own institution. So, even if they failed all the standard therapies, there are options for those patients, and those patients want options, but there are options for those patients at that same institution that they can access. But if you're in the community out there, whether you don't have all those options for clinical trials, then your patient is demanding what's the next step. They want to know what else can you do for them. And tumor profiling right now is the most accessible option to them to try to decide what am I going to do next? Can I actually do an off-label use of something that might actually benefit the patient? So, and you know, I mean, this is just my experience. I don't think there's any data on that supports this, but this is from conversations that I have, not only here in the U.S., but you know, we do a lot of work with Latin American oncologists, and over there, the lack of access to clinical trials is much stronger than, you know, even our community oncologists here, and that's the reason why they actually want to do these tests.
That's a good point. Maybe we can even add to that and say, so we do these tests, and this is most of what my practice is. Then what do? We have a tumor board, and we decide that the lung cancer patient has a HER2 mutation, and we want to give one of the drugs that might target that. If we actually have Anthem at Yale, if we call you or one of your people, Jennifer, would that be paid for?
I don't believe Herceptin for lung cancer is covered, no.
Right, so what do others think about this? Pat, you would probably want to have a phase 1 trial available, but if there wasn't one?
Well, and we felt that it was a relevant, actionable mutation. We would try to push to see if we could get it funded or get it on a compassionate basis to just, because I think once you've got the data, I mean, you know, Rich was talking about incidental findings and acting on them. But once you have the data, you know, what is your obligation? Do you just tell them, well, you know, I can't get Herceptin, so this is meaningless even though you've given me a tumor biopsy? You know, we do try to get the drugs, but you're right. A lot of times when they're standard of care drugs, it's very difficult. That's why I want to get involved in it, Dr. Schultz.
Right, we heard about this yesterday. We also heard about basket trials from Dave Solit. So there are options for this. Yes.
So Adrian Senderowicz, Ignite. thing is, I wanted to ask a question actually that Rich Shilsky asked yesterday. And if we're trying to educate patients about these important mutations, either somatic or incidental, I think what's crucial is missing is that clinical oncologists, particular practicing oncologists, don't know much about this. And this is a critical lesion that who's going to educate these patients and how we can educate these clinical oncologists. I think Rich asked that. Should we include this in the fellowship program? Should be mandatory? Should be part of the certification for the boards? I mean, I think it's something that we need to think who's going to be the messenger for this information. And I don't know if anybody has any thought about it.
Well, I can tell you that the lack of, I mean, I'm not even a, genomics expert, but the lack of information with a lot of these oncologists is frightening. And then you get these reports where they're telling you what clinical trial you should go on. But even worse than that, I recently had a patient a few months before I left that had 3 actionable mutations with drugs that were FDA approved that had never been tested in combination. And her medical oncologist sent her to me with 3 separate prescriptions and said, if Dr. LaRusso doesn't have a clinical trial for you, and the patient had enough money to be able to go out and pick up everolimus on her own, as well as a couple of the other oral drugs. And she said, if Dr. LaRusso doesn't have a clinical trial for you, I want you to buy these 3 drugs and start taking them. And she gave them as monotherapy, online labeled, in dosing. And I'm like, whoa, even if I don't have a clinical trial for you, you can't take those 3 drugs.
And who defines what is actionable? I mean, it could be an SMP. I mean,
it was in the report. The report.
Yeah, but the report, who validates that report?
Right. That's.
I don't know.
It was a foundation.
But with respect to your question of where these people should be trained, I mean, it has to start early. I mean, we're all getting retrofitted in our generation to sort of have some superficial understanding of this. But if it's really going to be ingrained, it has to come from early in training. And that's going to be incumbent upon the boards and so forth.
It has to be mandatory, I think.
Yeah. I know at Yale, the medical students, this coming year, they're going to have a whole new curriculum. They changed the curriculum 100%, totally different way of teaching. And included in each of the modules is an extensive, that is now included. I mean, it's a pretty cool way of going about it, but the mindset has to change, and we realize that, and some places are trying to do that.
As part of the lung map study, I mentioned it a bit yesterday, working with the NCI, Barbara and others, we're actually doing some questionnaires now. We're getting that set up to actually get a sense what the physician knows, what the patient knows, and try to at least gather some metrics so that we can now start to, as you say, educate the physician on how to make this discussion, because I agree it's a big issue.
Can I provide an answer to that? It's not a full answer, but I'm quite involved in the I-SPY trial, and we've been struggling a lot with what to do with findings that were not the main intent of the study. And what we've determined is on a case-by-case basis, where there's a group of people, including advocates, that are looking at whether or not to return the results. And when we decide to return results, we get some genetic counselors to develop some training that we do for the clinicians during a webinar for how to convey that information and also put together patient materials. And I think that might be an approach that works in the MATCH trial. And as a retrofit, I think it's sort of a reasonable start. I think getting the genetic counselors involved is very, very helpful.
Hi, I'm Michelle Dowdy from A.T. Still University. And the question, I have two questions. My first question is, we're talking a lot about the patient. However, what are we doing in terms of looking at ways to really develop a holistic model to educate the patients about genetics? In terms of breast cancer, only 1% of the population has a BCR, A1 and 2 genetic mutation. So as you articulate this whole targeted therapy for cancer, how are you going to make sure that the patient understands the information is accurate, and what is inhibiting the panel from doing this?
Well, I think that's where, that we do have to educate the patients, absolutely. How we educate them, currently we try to bring a genetic counselor on board who hopefully will understand the data and the geneticist, but I think that research is now just starting in some of the guys that are doing the educational aspects. There needs to be more work on educating the patient. How do you develop the tools? What type of tools? All patients, no patient is created equal in terms of knowledge base and background and things. This is an issue that I think a lot of people are trying to work on.
Well, and I like the word better, engaging the patient, not educating. Education sounds paternalistic to me, like we're going to teach people. A lot of people want the doctor to make the decision, but they want to be engaged in the decision and understand the decision being made, but they may not care diddly squat about understanding genetics. The average American person has about a 7th grade reading level. They don't understand statistics and probabilities, and so you can't really educate in that way. You can engage, and I absolutely think you have to engage patients.
Great. Well, thanks. We're at the end of our hour. It's been a wonderful session. I want to thank all the speakers, all the questioners, and we have a 15-minute break. We'll come back at 10:15 for session 5, the business model for test development. Thank you.